Hello everyone, good evening.
Good evening.
Um, so we started with um, E. coli yesterday, and we said E. coli is one of the gram-negative that is Indo positive because it has the enzyme that allows it to convert tryptophan to Indo. So it is Indo positive. It has three major virulence factors, which includes the fimbriae, the K capsule, and the endotoxin. The endotoxin is responsible for the ability for the E. coli to cause septic shock. The capsule is responsible for its ability to cause pneumonia and meningitis. So it's able to escape the macrophages in the lung, causing pneumonia, the macrophages in the brain, causing meningitis. And with the aid of the fimbriae, it can cause urinary tract infection because it has the ability to attach itself to the uroepithelium um, of the urinary tract. We talked about the strain of E. coli that is responsible for causing GI problems. We said there are four: the enteroinvasive, the enterotoxigenic, enteropathogenic, and enterohemorrhagic. We said the enteroinvasive typically invades the gastric.
Sorry, Baba. Sorry, Baba Wale. Sorry to disturb you. I was just thinking, in case I don't know if you're recording, because sometimes I think you do forget to record, and it's quite when we go back to look at it, we find out that it is not been recorded. I don't
Yes,
know.
so I'm sorry about that. I'm actually recording. What
Okay,
happened
thank
that
you.
last time was because my system had issues, so it crashed
No
and
problem. No problem.
wasn't able to.
Thank you. Thank you for that. Just for in case someone is not here.
Yeah,
Thank you.
that's well noted. Thank you so much. So, for the enteroinvasive, it has the ability to invade the intestinal mucosa, causing damage to the mucosa, and that will trigger inflammation. So, in response to the necrosis, there's inflammation. So, all these things together brings about the reason why it's able to cause bloody diarrhea, which is dysentery, because it has damaged the mucosa, it has invaded the blood vessels, as well as the gastric mucosa themselves. So, enteroinvasive E. coli will cause dysentery. Enterotoxigenic E. coli will not cause dysentery, but it will cause watery diarrhea because all what it does is just release its toxin, the heat stable and the heat lipid toxin, and we know the way they work. So they are just going to disrupt the normal mechanism by which it reabsorbs and secrete water, leading to the watery diarrhea. And it is responsible for causing the traveler's diarrhea, which we typically encounter in people that travel after consuming water that is infected with this E. coli. Enteropathogenic E. coli um, is another form, and this one is not invasive and it doesn't even produce any toxin. All it does is just to attach itself to the epithelial surface of the mucosa, blunt the surface of the villi there, which is the structure that they use to absorb um, electrolytes and fluid. And from there, the person will have diarrhea. So that's the enteropathogenic. And it's very commonly implicated in causing diarrhea in pediatrics. Just like Campylobacter jejuni is responsible for causing bloody diarrhea in children. Enterohemorrhagic E. coli, we said this is the one that brings about the hemolytic uremic syndrome, which is a triad of anemia, thrombocytopenia, and AKI with a background dysentery because it releases the Shiga toxin just like Shigella. The Shiga toxin removes adenine from rRNA, which makes up part of the 60S subunit. This brings about a cessation of protein synthesis. There is necrosis of the cells, there is inflammation, and it brings about dysentery. So the Shiga toxin at the same time activate the coagulation cascade, which brings about the triad of the hemolytic uremic syndrome, just like we have said yesterday. And this particular species of E. coli, we get it when somebody consumes raw leafy vegetables or undercooked meat, especially undercooked meat. So, OH157H7 is a strain, the serotype of this enterohemorrhagic E. coli that is responsible for this presentation. That happened a long time ago. So, that's the most common serotype that causes this hemolytic uremic triad, the OH157H7 serotype of this enterohemorrhagic E. coli. So we can see enterohemorrhagic E. coli, we can see E. coli OH15787. They are the same thing. Klebsiella. So said Klebsiella is another gram-negative rod that is highly encapsulated. It's a normal commensal of the oral cavity and the GI, and it can cause the common species for Kleb that we usually talk about is Kleb pneumo, and that one can cause pneumonia. It's typically cause pneumonia in people that aspirate. So by the time they aspirate, the oral secretion that they aspirate into the lungs contains anaerobe. So that is why in aspiration pneumonia, two organisms can be implicated, anaerobes as well as Kleb. We also said people that are immunosuppressed, particularly people that are diabetic and people that consume a lot of alcohol, they're also predisposed to developing infection from Kleb. And we said because of the thick capsule that it contains, by the time it gets aspirated into the lung, it can easily form abscess within that lung. So Klebsiella is also one of the organisms that somebody can culture from a lung abscess. Somebody can also culture anaerobic organisms because both of them can come in through the aspiration. We said the inflammatory response it causes in the lung is associated with production of currant jelly sputum. So someone that has Klebsiella pneumonia, the person will produce the currant jelly sputum. And we talked about the sputum color for the other organisms like Pseudomonas, like strep pneumo. So strep pneumo is rust, Pseudomonas is green, Kleb is currant jelly. Talked about Campylobacter jejuni, and we said this guy is comma shaped, so it's one of the cup shaped organisms, just like Helicobacter pylori, as well as vibro species, so Vibrio cholerae and the likes. The vibro, the Helicobacter pylori, and Campylobacter, they are the curved gram negatives. And Campylobacter jejuni itself is thermophilic. It can grow at temperature of 42 degrees Celsius, and it causes essentially dysentery in children. It causes um, reactive arthritis, and it can be an antecedent infection to somebody developing Guillain-Barré syndrome. That is all about Campylobacter jejuni. You want to remember it for three things: dysentery in young people, Guillain-Barré, as well as reactive arthritis. We also talked about Vibrio cholerae. That Vibrio cholerae can be gotten, it's one of the curved organisms just like Campylobacter jejuni, can be gotten from uh, consumption of water that is contaminated with this vibrio species, or people that consume uncooked food that are gotten from from the sea, like seafoods that are poorly cooked, or contaminated water that is infected with this microbe. So it typically causes cholera. That's cholera, rice water, diarrhea. So the mechanism is that once somebody takes in this Vibrio cholerae, it releases the cholera toxin, which permanently activate the GS subunit, bringing about increased secretion of CMP, that brings about increased secretion of sodium chloride and water, which explains the diarrhea that they have. And the diarrhea is not bloody. We should not forget that all the curved organisms, they are oxidase positive. So Campylobacter jejuni, Vibrio cholerae, Helicobacter pylori, they are all oxidase positive. And the additional feature for Campylobacter, it can grow in 42 degrees Celsius. Additional feature for this Vibrio is that it can grow in alkaline medium. So if somebody takes in Vibrio cholerae, there are some protective mechanisms that can protect somebody against this infection, and that includes the gastric acid. By the time it comes in, some of these organisms are destroyed by the gastric acid content, just like Salmonella. But Shigella is resistant to the gastric acid. Salmonella and Vibrio are sensitive to the gastric acid. So anybody that has any condition that reduces the gastric acidity, the person can develop Vibrio cholerae infection easily. So, for example, somebody that has pernicious anemia, somebody that has achlorhydria from anything, maybe the person is on PPI or anything that can reduce the gastric acid level, uh, the person is highly predisposed to developing this infection, provided the person get exposed to food source that contains the vibrio species. So we said the treatment modality is just giving ORS. So just rehydrate with salt, sugar containing solution. That is all. There's another species of vibro that is important to also know, which is a vibro vulnificus. So this one is also found in marine environment, basically, and all what it does is just to cause wound infection. So when there's a wound in the body and the person is exposed to sea or ocean water that is salty that contains this vibro, the vibro can easily penetrate and enter that wound and cause cellulitis. So in some people that are immunosuppressed, particularly people with liver disease like liver cirrhosis or people with hemochromatosis, this vibro can easily proliferate and thrive in that kind of person and penetrate deeply into the infection, into the tissue, go as deep as reaching the muscles and the fascia and cause necrotizing fasciitis. So in that kind of person, we might want to do an aggressive debridement. We want to remove all the necrotic matter so that we can eradicate that vibro organism completely. So the clinical significance of vibro vulnificus is just cellulitis and necrotizing fasciitis, which can disseminate into sepsis in people with an underlying liver pathology, either chronic liver disease like liver cirrhosis or iron overload in the liver like hemochromatosis. So we should be watching out for any of them. And we buttress that with a question that we saw on the page today. And I'm happy that most of us were able to answer that perfectly. Helicobacter pylori, this is another curved organism. It is motile, so it is triple positive, positive for catalase, positive for oxidase, positive for urease. So the urease positivity explains part of its virulence factor. So this urease enzyme can allow it to split urea into CO2 and ammonia. The CO2 will find its way outside through the respiratory tract to the environment, and that is the basis of the urea breath test. So by the time we do a urea breath test and we're able to demonstrate efflux of high amount of acid from the breath, we know that the person is actually having Helicobacter pylori infection. This urease enzyme also allows it to do the splitting, and the ammonia there can neutralize the acidic region in the stomach so that it can colonize the stomach and be protected against the acidic region in the stomach and cause infection. So what is spectrum of infection that it causes? It starts with a chronic inflammatory process, because we've said it in our pathology. When inflammation becomes progressive, when it's very difficult to eradicate the insulting agent, it moves from acute inflammatory response to a chronic response. So that is why, because of all these virulent factors, which is actually more than urease enzyme, it has so many things that allows it survive in that acidic region and cause problem. But we are not really looking into that. So urease is enough for the sake of our exams. So it stays there for a long time and it's very difficult to eradicate, and the inflammatory process will progress to a chronic inflammatory state. So that is why Helicobacter pylori infection can cause chronic atrophic gastritis of the GI tract in the stomach. Then from there, the arthritis that causes brings about damage to some of the glands there, and there's a drop in the secretion of acid. So, because of that, there's a response to release gastrin, and the gastrin response will stimulate all the gastric glands to hyperproduce acid, which explains the reason why it can cause peptic ulcer. The gastritis can also progress to intestinal metaplasia, so it has some enzyme, some factors, I won't call them enzyme, some factors like CAT-G that it uses to drive that metaplastic change. So from the normal epithelial to intestinal metaplasia. So from the intestinal metaplasia, it can now go ahead to become dysplastic, then to eventual gastric adenocarcinoma. So that is why it can cause atrophic gastritis, intestinal metaplasia, gastric adenocarcinoma. Then it can also eventually lead to peptic ulcer rather, then the malt lymphoma, because it can also colonize the lymphoid tissue that are present within the gastric mucosa, cause malignant transformation of the B cells within this lymphoid tract, making them develop the mucosal associated lymphoid tissue lymphoma. So there's hyperproliferation of the B cells within those lymphoid tissue. So what is a treatment option? A triple therapy or a quadruple? The triple therapy is okay, and that is the APC, amoxicillin, uh, clarithromycin, which is the C, then the P is the proton pump inhibitor. We are giving the antibiotics to the proton pump inhibitor so that we can kill off the microbe. So you need to eradicate the microbe. If somebody have multiple lymphoma, gastrointestinal or peptic ulcer disease, and the person is positive for Helicobacter pylori, you need to eradicate that organism, or else that pathology will not resolve. We talked about the spirochetes, three organisms: Leptospira, Borrelia, Treponema. Treponema pallidum, Leptospira interrogans, Borrelia burgdorferi. We said these guys are spiral-shaped organisms that have axial filament. We cannot see two of them, which is Leptospira and Treponema. That is why we cannot gram stain them. Because if you gram stain, you might still need to look at it under a light microscope and you cannot appreciate anything. But Borrelia can still be seen with light microscopy. But we have to use some special stain also, which is either the Giemsa stain or the Rice stain. But Treponema and Leptospira, if you want to see it well, just use dark field microscopy. We are going to see them fluorescing, emerging, distinctively against a dark background. That is the dark field microscopy. We talked about the Jarisch Erigima reaction. So this is just like a short course inflammatory response to commencement of the antibacterial for treating the spirochete. So if somebody has leptospirosis, treponema infection or Borrelia, and we give the drugs, for example, in treponema, we give the what drug do we give for penicillin? So we give the penicillin G for the treponema, and immediately we start that penicillin, the person starts developing the fever, the chills, the rigor, the headache, the malaria, the nausea, and all those things. We know these are constitutional flu-like symptoms that is due to the dissolution of the organisms from the antibiotic and immune response to those antigenic protein that are released from those uh, bacterial molecules that have been broken down. So when the antibiotics start working and destroys the bacteria, the antigens that are released are the ones that provoke the inflammatory response that brings about this constitutional symptom. That's the Jarisch Erishma reaction. Lyme disease. That is a disease that is caused by Borrelia burgdorferi, which is one of the spirochetes. The vector is the Ixodes deer tick. We said in addition to transmitting Borrelia, it can transmit two other things: anaplasmosis and babesia. So it can cause anaplasmosis and babesia. Babesia is like white man's malaria. The basic presentation of babesia is just fever and hemolytic anemia. Anaplasmosis, they can present anyhow. All the constitutional symptoms will be there. Then, in addition, you can have bleeding and also signs and symptoms of end organ damage. So, anaplasmosis, ehrlichiosis, all those ones, they are non specific. You cannot distinguish them clinically until you do your laboratory investigation. But Borrelia can be picked clinically because we are going to see the clinical presentations in stages, depending on the stages where we catch it. Stage 1, stage 2, stage 3. Stage 1 is the early localized stage. So once you see that presentation, most likely we'll be able to make a diagnosis that this is likely to be Lyme disease. So the early localized phase where the patient just have erythema migrans, which is this target-like lesion within the area of bite of this tick. So we can see the way it looks like. This is erythema migrans. Call it erythema migrans because it can move from this side to another side. So by the time it starts progressing towards stage 2, which is the early disseminated phase, this rash can appear in other regions of the body, different from the site where the tick had introduced the bite. So we call this the early disseminated phase. So the three presentation for uh, the acronym for this early disseminated is what we call the MAC. So we said the MAC. The M is malaria or the meningitis. So they have this meningitic presentation. The myalgia, which is transient. The A is the arthritis. They have this transient arthritis. Then the C is the carditis and the cranial neuritis that they have. And the particular cranial nerve that is commonly affected is what? Cranial nerve 7. So they have signs and symptoms of Bell's palsy. So that's why, in addition to uh, the other things that can cause Bell's palsy, Lyme disease is one of them. There's a lot of things that can cause Bell's palsy. Lyme disease is one of them. As the second stage presentation, Bell's palsy, due to the um, neuritis of the seventh cranial nerve. So that's the C component. So this second C is the carditis. So it can cause inflammation of uh, the the heart itself, carditis, and that can destroy the electrical system, bringing about a second or a third degree, but commonly a third degree heart block. So it can also cause heart failure. It can lead to arrhythmias. Can lead to so many things. But most commonly, we link Lyme disease to third degree heart block. So that is a feature of the second stage. Third stage, the person is already having this arthritis that is now chronic for more than 6 months. The person is now having neuropathy, peripheral neuropathy, tingling sensation in the legs, numbness, pain. Then encephalopathy, which is constellation of cortical dysfunction. So person loses his memory, has cognitive deficit, personality changes, um, is just confused. So problems with memory, with judgment, with personality, all those things. So that's the feature of this encephalopathy that they have, which is a third stage. So how do we treat someone that has Lyme disease? The mainstay of treatment is doxycycline. But in pregnant people or children less than 8 years, because of the teratogenic effect of doxy, we want to give our amoxicillin. If we catch it at the disseminated phase, we want to give IV, intravenous, not even oral, intravenous ceftriaxone. Leptospira interrogans. This one, we said it happens in two forms, leptospirosis and severe form of leptospirosis, which is Weil disease or icterohemorrhagic leptospirosis. We said the catch, the clinchers for leptospira that we are looking out for is just number one, anything that talks about affectation of the liver. So there's jaundice because that's the primary organ that the leptospira affects. So somebody get this leptospira guy from contact with animal urine. So and maybe water or food that's already contaminated with the animal urine, the person can get this leptospira and it attacks the liver. So the person develops jaundice. And the most characteristic sign that you want to look out for in your exam is what? The conjunctival suffusion, which is redness of the eye without any discharging exudate, as well as calf pain. So once we see calf pain, back pain, see, forget the back pain. I don't like mentioning that back pain because what you see in the exam is calf pain. You put it like that. Calf pain, the conjunctival suffusion, the jaundice, we know we are dealing with. So with the conjunctival issue, the eye issues also are here with photophobia. But I don't really like mentioning that photophobia so that people will not be saying meningitis. But it's better to also know that we can see photophobia in some. So photophobia can be seen in someone that has rabies. Photophobia can be seen in someone that has meningitis. Photophobia can be seen in someone that has leptospirosis. But those are not. That's not the major clincher. So we are looking for the calf pain, we are looking for the conjunctival suffusion and the jaundice, leptospirosis. Then, when it now becomes severe, it affects the kidneys too. The person will have features of AKI, all the electrolyte, the urea, nitrogen, everything is over the roof. The person is still having severe jaundice, which is so deep, and affectation of the coagulation cascade. The person is bleeding, which can progress to cause anemia. So that is the real disease. Syphilis. Syphilis is the one that is caused by the Treponema pallidum, and the mainstay for treating is penicillin G. We talked about the spectrum, the primary, secondary, tertiary, and congenital. The primary syphilis, what we are looking out for there is just the painless ulcer at the genital area. So that point of sexual contact, that's where the ulcer develops. The penis, the cervix in the female. So we have this painless ulcer there that is firm, indurated, clean. It has a clean base. It is not, it doesn't have exudate. It's very clean. Primary syphilis.
Sorry, Dr. Bawali, did you say cervix in female or in the vulva?
No, cervix in the females. You can see it in the cervix. In the
Oh,
vulva, you can also see features of secondary syphilis in the vulva. So,
so for primary, you cannot see anything in the vulva.
well, you might be able to see, but most of the time, the lesion will be in the cervix.
Okay, all right.
So, yes. So, that's that about the primary syphilis. We are looking for the painless chancre. So, once you see the painless ulcer, painless, our mind should be going towards syphilis. Painless. But there's associated lymphadenopathy. Inguinal lymph node will be swollen and they will not be painful as well. So for secondary syphilis, that's where we are now looking for the triad. Lymphadenopathy, lymph node problem, skin problem, mucosal problem. So there's a generalized lymphadenopathy. There is skin problem, which is what? The maculopapular rash that covers most part of the body, extending as far as the palm and the soles. So we don't have too many rash that crosses the palm and the sole. We don't. But syphilis in the secondary form is one of them. Then the third one, sorry, the third one talking about affectation of the mucosa is condylomata lata, where we have smooth wat-like lesion on the genitals. So somebody having this wat-like something that looks like HPV infection, white-like, but white now. Lesion affecting the vagina, the vulva area, the vagina, just the vulva, the outward part. You can see affecting the labia majora already here. You can see it here. So and the external part. So that is the condylomata lata. So then we've talked about the lymphadenopathy, we've talked about the maculopapular rash, which extends to the palm and the sole. So that feature is very important. When you see it in the question, extend to the palm and the sole. Syphilis is one of the considering diagnosis. Syphilis, secondary syphilis, palm and the sole affectation. So in addition to syphilis, you also have some other ones which include Coxsackie viral infection or the rickettsial infection, which we are going to talk about just in some moment now. So that is that about the secondary syphilis, but at this secondary stage, it can progress to latency, in which you won't see any symptoms. But if you test for the person serologically, it will be positive. So we'll talk about the test very soon too. So tertiary syphilis, we are just looking at three things: the gummas, the affectation of the CNS and the brain. Gummas is just chronic inflammatory lesion everywhere in the body. We can see it anywhere, but most commonly they are present in the skin. They will disfigure that part. The person will look like this. Which other diagnosis can we give this person? Anybody? I want to see if you can remember. Looking at this person's face.
Lepra.
Yes, thank
Lep-
you. So, what form of leprosy are we saying specifically?
Lepromatous. The
Lepromatous lepra.
Thank you. So, this guy is looking like someone that has lion fasci, lepromatous lepre. So, that is that. Then aortitis due to damage or the obliterative end arthritis of the vasa vasorum. In fact, that's what they will put in the option. So you'll be able to identify that this is syphilis. The next thing is what is the mechanism of causing this cardiac presentation? Inflammation of the vasa vasorum, the vessel that supplies the vessel. Then we talk about the neurosyphilis, which is uh, damage to the posterior column. So from tabes dorsalis, it can cause generalized paralysis, general paralysis of the insane. So the person is having delusion, hallucinating, confused, depressed, and the person cannot even move. Generalized paralysis of the insane. That's one of the features of tertiary syphilis. Then the Argyll Robertson pupil. You shine light, the pupil doesn't constrict. You put a book close to the eye, the pupils constrict. Argyll Robertson pupil. So we know the signs: stroke without hypertension, Charcot joint, Romberg test positive, the broad-based ataxia. The congenital syphilis, we said this one is when a baby develops syphilis. So if a mother transmits the syphilis to the baby, what happened? Congenital syphilis. So yes. So we can see this one because it might not be really fatal. So they don't really die like die. It's not like all this Pavo B19 that will kill from eye drops. I know rubella too they survive because all those ones don't really cause much. Maybe just cause some PDA, eye lesions and cataract. So the baby will still survive. So we can see all these ones. So congenital syphilis, the nose, the mouth, the hair, the leg. So what happens with the nose? What are we looking out for in the nose? Saddle nose. So saddle-shaped nose. There is incessant snuffles. So the baby is always having rhinorrhea. We go to the mouth, the hem, mouth, hem, the molars, mulberry molars, the maxilla, hem is short. We look at the teeth in front. So we are looking at two teeth, the molars and the incisors. So the incisors in front, the molars at the back. The incisors in front are notched. We call that the Huntington teeth. The hair, there's tendency for the baby to be deaf because of affectation of the vestibulocochlear nerve. They look at the leg, particularly the tibia bone. The tibia bone is convex, like we are bending it. Sabra shin. So the way we can prevent it is to quickly treat the mother before the mother progresses to the second and the third trimester. So these are the features of you can see the snuffles, the saddle nose, the raggedies. So raggedies are just like linear lesion at the corners of the mouth. You can see this black arrow showing the raggedies. We can see the Huntington teeth, which is talking about the notching within the incisor teeth. So those are the features of congenital syphilis. By the time they are painting the question, we already know what they are talking about. It's very simple to identify. So let's talk about diagnosis of syphilis. So we have different modality. We can use serology or we use direct testing. So direct testing means you are looking at the organism live or you are looking at the DNA of the organism. Very easy. So looking at the DNA, how can you look at DNA of an organism? You do your PCR, very easy. Nucleic acid amplification test, PCR, polymerase chain reaction. Or you look at it in the microscope, and we have said it. The only microscope that we can use to look at this guy, syphilis, which is one of the spirochete, and identify it clearly is using a dark field microscope. So that is the direct test because you are sure that what you are seeing is syphilis. If you are looking at the DNA of syphilis, there's no other organism that can. Everybody have their own distinct DNA. It's unique to everybody. So that is a direct test. But serologic testing, you are deciding, you are making your diagnosis based on antibody antigen reaction. There might be so many things that can cross produce all those antigen antibody. So you now have sub classification of that serology into the serologic tests that are treponema specific and the ones that are non-treponema specific. So this non-treponema specific one means that you can easily have other organisms, other situations, bringing about a positive result that is not actually due to treponema. So that is it. So it means that the better one is actually the treponema specific serology testing. So what are the non-treponema specific serology tests? The rapid reagent reagin, which is RPR, and the VDRL, the Venereal Disease Research Laboratory Test. These guys are the same thing. Very easy. What they are just doing is that somebody that has syphilis can produce anticardiolipine. So anticardiolipine is one of the antibodies that is produced in someone that has syphilis. So what we do is that we introduce beef cardiolipine. So that muzzle of the beef, heart muzzle of that cow, that's beef. It contains this cardiolipine. So it means that there's an antigen ready to the antibody in someone that has that syphilis. So what we now do is that we put them on a slide, then we introduce the serum of the person with the syphilis that contains the anti-cardiolipine antibody. Then we add the beef cardiolipine to it. So we expect a reaction. We examine in a microscope. We see the flocculation. That is the VDRL test. Very easy. We are just using beef cardiolipine against the anti-cardiolipine antibody that is present in the serum of somebody that has a syphilis. For the rapid reagent reagent, you are just adding a reagent to that mixture so that you can appreciate the flocculation without you needing to use a microscope. That's the difference between two of them. So in fact, rapid reagent RPR is so easy compared to VDRL because you can see the flocculation without you using your microscope. Both of them, they use the same basis for their testing. So where the problem now lies is that it is not only syphilis that can produce this anti-cardiolipin antibody. There are some other conditions. So for example, someone that has lupus nephritis, systemic lupus erythematosus, someone that has leprosy. So the code is still this VDRL, false positive VDRL. So P is for the pregnancy. We can see the acronym on the screen. P VDRL. So just remember VDRL. Add pregnancy to it. VDRL. V is a viral infection, Epstein-Barr virus, hepatitis B. So someone that has Epstein-Barr virus, someone that has hepatitis B, someone that has the D, which is a drug. So the way I learned this drug is that I know that these drugs have tendency for causing drug-induced lupus, chlorpromazine and procainamide. So chlorpromazine, and they even sound similar. So for some of us that have done cardio, what class is procainamide? Anybody? Procainamide. This should be spinal.
1A.
Yes.
Class 1.
So procainamide is a class 1A. Yes. So what did they do in terms of how am I going to ask this question now? What did they do to the action potential? Do they prolong it? Do they stabilize it? Do they shorten it?
Yes. 1A, they prolonged it.
Prolong the action potential. Why? Do you know why? Can you
Um,
identify the cough when you see it? Can you identify the
yes,
cough? Okay,
yes.
that's fine. So what are you looking out for class 1A?
They are sodium channel blockers, kind of. And they also have, I think they have, I think they have class 3 too. But the curve shifts to the right.
To the right. That's very correct. So you are going to notice that the phase 3 that is caused by potassium,
Yes,
is
it's
moving to. So
prolonged.
that's the stuff. That's just what you need to look out for. Just know that shift in the potassium one because they also uh block potassium channels. That is it. Just like your class 3 can do. So that's why they prolong the action potential. You see that the curve is also widening to the right. Why for class 1B? It is not like that. So then your class 1C doesn't touch it. So all right. So that's just by the way cardiology. Rheumatic fever is the R. Then the L is a lupus, leprosy, and lupus erythematosus. So we should just remember the V, the viral agent, Epstein-Barr virus and hepatitis virus. The R, we are talking about the VD, D, the drugs, procainamide and chlorpromazine. The R, rheumatic fever, which is very rare. Then L is the lupus and leprosy. So we should know that these drugs too, they can cause lupus. So then that's all about the RPR and the VDRL. The treponema specific, that one too, we are using antibody, but the difference between this one too is that for the non-treponema one, we are using only the beef cardiolipin as the antigen source. Here, the antigen source is the whole molecule, the whole organism of the syphilis is a whole organism. So there's no way anything can cross-react with it. It is the whole organism that is the antigen. So they just get the dead syphilis organism, they prepare it in the slide, then we introduce the serum of the person that contains the antibody. We try to put some smear that will absorb it to that surface. Then that antibody is added to a fluorophore, so something that emerges light, something that brings out light when there's a reaction. So by the time you mix everything together, there's a reaction, you see the fluorescence. So that's the fluorescent treponema antibody absorption test. That's the FTA ABS. Very easy. The same thing for the treponema pallidum particle agglutination. That's the TTPA. All these tests they don't ask. Me, I'm just explaining it for knowledge sake. They will not ask. They don't really ask. So TTPA The difference between TTPA and FTA is just that we are not really putting a fluorophore for TPPA that emerges light. No. So we are just adding the antigen, we are adding it to a gelatinous material. So a gelatinous particle that can hold it. Then we now add the serum that contains the antibody. Of course, that antigen that we're adding to the gelatinous particle contains the whole organism. That is just another stuff. So it's just like FTA, it contains the whole organism too. We add it to a gelatinous material that fix it, we add the antibody from the serum, and there's going to be EMA agglutination. So it is the agglutination that we see that we can now say, okay, this is positive for. So it is treponema specific because it contains the whole treponema antigen, not like the non-treponema one that contains the beef cardiolipin, which is the antigen source. So that is that. So the take home here is just that the non-treponema one, they are very fast and they are very sensitive. You can quickly do it to screen people, to screen people. But the only way you can make diagnosis with serology is doing the treponema specific one. Of course, the direct testing is very absolute, but you can imagine the cost. This dark field microscopy is very expensive. Then PCR, PCR is not something that you just do anyhow. You need to have that equipment. So the best way to do it is just make use of this treponema specific, and that's when you can say that your diagnosis is actually sure. But for screening, you use the VDRL test. So for the primary infection, particularly, you just screen with the VDRL test. You screen primary infection. But if you want to start making diagnosis of secondary and tertiary infection, you need to use something better, which is the treponema specific test, FTA and then TTPA. They are very good to make diagnosis of the secondary and tertiary infection. So particularly to rule them out. Once FTA, TTPA is negative in somebody you are thinking has neurosyphilis or any secondary or tertiary infection, you know that that person truly doesn't have it. So you can say it has a negative predictive value. So once you do it and it's negative, you can confidently tell that person doesn't have it. So that's about the use of this treponema specific in making diagnosis of syphilis. Chlamydia. So chlamydia, just like Rickettsia, is one of those obligate intracellular guys. They stay entirely within the cell that they are affecting. They depend on that cell for its own ATP. It has to form the elementary body and the reticulate body. So the elementary body, from the way it sounds, the body, the form that it gains entry, entry, that's the way it enters the cell and cause the infection. That's the infectious form. So that's what we need to really understand. The elementary body is a form by which it gains entry into the cell and cause infection. But all about this reticulate body is just replication by binary fusion. That is it. Reticulate body is just replicating within the cell. That is it. So that's that about chlamydia. And we remember when we were talking about chlamydia then, we said chlamydia is one of those organisms that we cannot gram stain, because of two reasons. It is intracellular and it lacks the classic peptidoglycan cell wall, which has very reduced component of muramic acid. So that is why beta-lactam antibiotics cannot work against it. We said that day. So we want to consider the other options for treatment like doxy, azithromycin. So we cannot use ceftriaxone, we cannot use penicillin. So doxy is the number one for chlamydia. Once you hear chlamydia, doxy is the first thing. So there are different species for chlamydia. We have chlamydia trachomatis, we have chlamydia pneumoniae, chlamydia psittaci. So the important one, majorly that they commonly test, is chlamydia trachomatis. So this guy is responsible for causing eye infection as well as genitourinary infection. So it causes eye infection and genitourinary infection. The eye infection can occur both in adults and in children. So the eye infection is what we call follicular conjunctivitis. So adult follicular conjunctivitis. In children, it causes the neonatal conjunctivitis. That's the Ophthalma neonatorum. Just like what's the other organism that we said can cause neonatal conjunctivitis? Anybody?
Group
When
B streptococcus.
What did you say?
no
Group B streptococcus.
What did you say?
neonatal conjunctivitis following delivery of a baby is not group B.
Is
Group
it
B,
Neisseria? And Neisseria gonorrhea.
yes, Neisseria
Yes,
gonorrhoeae.
gonorrhea. Yes.
It is not group B is MOPS. You remove the O,
Yes.
meningitis, pneumonia, and sepsis. So Neisseria gonorrhoeae and this chlamydia trachomatis, they are like brothers. They have so many infections that they cause in common. One of them is the neonatal conjunctivitis following delivery. So we've said chlamydia trachomatis can cause genitourinary and eye infection. So we said the eye infection is what? The follicular conjunctivitis in adults, the neonatal conjunctivitis in babies. The genitourinary, there are two components. Urinary, that's the urethritis. So let's just stop there. Urethritis, inflammation of the urethra. Then the genital component affecting the genital tract. So in females now, it can affect the cervix, the uterus, the fallopian tube, the ovaries. So it can cause a cervicitis. And when there's ascension of cervicitis to the uterus, to the fallopian tube, to the ovaries, what do we call that? Infection of the uterus, the fallopian tube, and the ovaries. What do we call that? Anybody?
PID. PID.
That's a pelvic inflammatory disease. So, just like gonorrhea too, these guys can also cause a PID. So that is how to remember the constellation of infection from this guy. And we said it again that uh, the commonest cause of reactive arthritis is which organism? Anybody?
Chlamydia and
Chlamydia. Chlamydia is the commonest cause. We just have some
yes,
other
Chlamydia.
organisms.
another one.
We just have some other
Yes.
organisms that can cause like Yersinia, like Campylobacter, Shigella,
Yes.
Salmonella.
Salmonella, Shigella,
But the most important one to always remember is
chlamydia.
Chlamydia
Chlamydia.
trachomatis. Chlamydia trachomatis. So if we don't see Chlamydia trachomatis, then we can be looking out for Campylobacter jejuni and our Yersinia. So don't forget the urethritis that chlamydia cause, which is the urinary component, genitourinary infection. The urinary component urethritis is non-gonococcal. We have said it that urethritis is divided into gonococcal and non-gonococcal. It's just like arthritis. I don't know why they give this guy special treatment. So they classify everything specially: gonococcal and non-gonococcal arthritis, gonococcal urethritis and non-gonococcal urethritis. So non-gonococcal urethritis, chlamydia is one of those things. So to watch out for. So what are the other strains for chlamydia? Chlamydophila pneumoniae and Chlamydophila psittaci. So Chlamydophila pneumoniae will be one of the causes of atypical pneumonia. So this is pneumonia that is caused by an organism that is outside normal Klebsiella pneumoniae and strep pneumo, atypical. We are going to talk more about the atypical guys later. We'll get there. So, Chlamydophila psittaci can cause psittacosis. So those guys just be having, they cannot really ask that. It's not relevant. So Chlamydophila pneumoniae can cause atypical pneumonia. I think that one is important to know that chlamydia can also cause pneumonia. So particularly the Chlamydophila pneumoniae form. So how do we make diagnosis? We make diagnosis by using PCR. Okay, so the reservoir for this Psittaci one is the parrot. They cannot hack, but let's just mention it so that we just know. Psittaci is parrot, so it's a zoonotic infection because we can get the organism from parrots. So how do we make diagnosis of chlamydia? PCR analysis. Fine, it's good. If you remember that, then we can stain the chlamydia. Of course, we said it. Cable. Chlamydia is stained by Giemsa stain. How do we treat? Doxycycline. That's a major one. So in people that are pregnant that we want to avoid doxy, we can give them azithromycin. So, and we remember when I was talking about treatment of all these urethritis, this PID, and because we know that both of them commonly they are caused by Neisseria and chlamydia. So if you have made diagnosis of one and you have not ruled out the other one, you have to give antibiotic cover for the other one. So if we are able to rule out that, okay, this is chlamydia trachomatis causing PID, we give our doxy, we must always add ceftriaxone to it to take care of Neisseria if possible, Neisseria is also there, unless you rule it out. So we have to understand it very well. If we make diagnosis of PID and we're able to culture Neisseria, we give antibiotic for Neisseria, which is ceftriaxone, and we also provide cover for chlamydia if we have not ruled it out. Those guys are brothers. So, what are the serotypes of chlamydia trachomatis? Not chlamydia, not chlamydophila pneumonia, not chlamydophila psittaci, but chlamydia trachomatis, which is the one that causes the eye, the genitourinary tract infection. So the way to always remember it is just that we classify it into three forms: the ABCD serotype, the D2K serotype, the L1, L2, L3 serotype. So we should just know that the ABC serotype, that is the one that causes trachoma, which is the follicular conjunctivitis in adults. So that's the one that affects the eye, ABCD. That's the first one. So that is the one that will cause follicular conjunctivitis that looks granulomatous. These things are like the follicles. So that's why so once you open the bulbar conjunctiva, you are going to see this trachomatous stuff, these follicles. So once you see this, you know that this is trachoma, follicular conjunctivitis that is caused by which is caused by chlamydia trachoma. So this infection is very common in poverty-stricken region. So sub-Saharan Africa, all those areas where there are so many flies, because this infection can also be transmitted by flies. It can be transmitted by fomites. So if somebody has used a towel to wipe that eye and somebody else uses it, the person can develop trachoma. So flies, fomites, poverty, those are the risk factors for developing chlamydia trachomatis, trachoma, or follicular conjunctivitis. We are done with that. So very common cause of follicular conjunctivitis in resource limited areas. The D2K, let's ignore that for now. Let's go to the L1, L2, L3. So we are going from A, B, C, D, then D to K, then after K we have L. So we are stopping at the L. So L1, L2, L3. So that is the one that can cause a genital ulcer. Just like syphilis causing ulcer, we can have an ulcer too in the genital tract. That is not syphilis, but lymphogranuloma venereum. So this is another cause of painless ulcer too. But the difference between this and the chancre of syphilis is that when we look at the surrounding lymph node, they will be swollen and they will be painful, and they can even ulcerate to form bulbos. Another thing that can cause bulbos is plague, and we are going to talk about it. So once you see painful inguinal lymph nodes that ulcerate, and there's an associated painless ulcer. So please don't let us mix it up. The ulcer on the genital tract, the penis, is painless, but the lymph nodes, they are painful. That is lymphogranuloma venereum, which is caused by the L2, L3, L1 serotype of chlamydia trachomatis. All the other infection of chlamydia trachomatis will fall under D2K. So all the other ones, the neonatal conjunctivitis, the urethritis, the PID, all those ones fall under D2K. So another thing to just remember about chlamydia trachomatis, it can also cause neonatal pneumonia. And this pneumonia is characterized by eosinophilia and staccato cough. So it's not very, very high. They rarely ask, this. So we should just know that in addition to causing neonatal conjunctivitis, it can also cause neonatal pneumonia. And it is not the chlamydophila pneumonia. The one in the neonatal pneumonia is from chlamydia trachomatis. It causes neonatal pneumonia, which is characterized by staccato cough. So they are coughing. The cough sounds like horn, like you are horning. I can't reproduce the cough, but it's actually coughing in between episode of inspiration. So the cough taking here, the cough taking here. So that had that high frequency sound, like as if you are horning, honking sound, staccato cough in children. But the most important there is just to remember lymphogranuloma venereum. Very important. We know that presentation. We are able to identify follicular conjunctivitis and chlamydia serotype ABC as the cause. All the other ones will fall under D2K. It can cause ectopic pregnancy as a complication of PID. So by the time we are doing our reproductive, we talk about that. So PID can cause ectopic pregnancy. By the time PID affects the fallopian tube, and there's addition, there's synecdoche, there's attachment of all those fallopian tube with the surrounding peritoneum, and the whole stuff is disfigured. It can affect the motility of the egg downwards to the uterus. So they would rather stay in those pockets of addition within those fallopian tube, and they will implant there and they will grow, causing ectopic pregnancy. So PID is one of the causes of infertility, one of the causes of ectopic pregnancy, and all those things. So, uh, um, moving on to some of the anaerobic infection, Gardnerella vaginalis. Very easy stuff. You see this. They ask it a lot. What is Gardnerella vaginalis? It's one of the ELAs. Automatically, we don't know the shape because it's a cocobacillus. We can't say if it's rod or if it's circular. Pleomorphic gram-negative rod, which is implicated in causing bacterial vaginosis. So we have three major vaginal infection that is troubling: bacterial vaginosis, Trichomonas vaginalis, vaginitis, as well as Candida vaginitis. So this Trichomonasis and the Candida one, they are actually inflammatory. Bacterial vaginosis is not inflammatory disease of the vagina, so they don't cause the cardinal signs of inflammation are not typically there. So they are actually how do I put it now, caused by this Gardnerella vaginalis, but it is not only this guy that is mediating that process. So Gardnerella vaginalis forms biofilm that allows the colonization of other anaerobes in the vagina. So it's just more like any condition that can cause disturbance of the or a disruption of the normal microbiota within the vagina. So normally vagina will contain some little anaerobes, it will contain even candida, it contains lactobacilli, most importantly. So the lactobacilli in a way tries to control those other anaerobes from causing problems. So by the time somebody does anything that reduce the level of this lactobacilli, probably the person is engaging in too much sexual intercourse, the person is abusing antibiotics, or the person is just practicing douching, vaginal irrigation. Those things can kill off the lactobacilli, and it will allow uncontrolled proliferation of those anaerobes, particularly Gardnerella. Gardnerella vaginalis will form a biofilm so that the other anaerobes will not superimpose themselves within the vagina and start causing problems. So the Prevotella, the Bacteroides, the Gardnerella, all of them work together to bring about the pathophysiology of this bacterial vaginosis. So bacterial vaginosis. So all of them are essentially anaerobes. How do they present? How will you distinguish it from Candida vaginitis from Trichomonasis infection of the vagina? It's going to present with someone that has this is going to present with a thin gray-white vaginal discharge that has a fishy smell. So once you perceive the smell, it smells like fish, gray thin vaginal discharge that has a fishy smell. Is one of the cardinal signs of bacterial vaginosis. It is not painful. Pain is one of the cardinal signs of inflammation. We have said it that it is not inflammatory. It is not causing vaginitis. So it is not painful. The trichomonasis causing vaginal problem and the candida, those ones will be painful because they are driving inflammatory problem. So uh, um, the classic thing is just having that thin gray-white vaginal discharge. And how do we make the diagnosis? So we just obtain a sample of the vaginal discharge, we mix it with 10% KOH, and of course there's going to be exacerbation of that fishy odor. So that's what we call the whiff test. So they talk about it a lot. So whiff test, mixing the vaginal discharge with 10% KOH, increasing the fishy odor. So, and we said it that any practice that kills off that lactobacilli, allowing for proliferation of the Gardnerella and the other anaerobes, causes wahala. So if lactobacilli drops, lactobacilli is one of the microbes within the vagina that helps maintain the acidic reach, because the pH of vagina is less than 4.5, is acidic. So by the time the lactobacilli is gone, the exotic produce fermenting lactose to release acid again, the pH will now be more than 4.5. It should be tending towards the alkaline range. And that's why one of the components of the Amstel criteria for making diagnosis of bacterial vaginosis is what? Vaginal pH that is more than 4.5. So the whiff test is also positive. That's another criteria for making diagnosis. So positive whiff test, vaginal pH more than 4.5. So what is the treatment? Because we know that the implicating microbes are what? Anaerobes. We just give drugs that can help us kill anaerobes, metronidazole and clindamycin. But the first line would be metro, because the way first aid described the utilization of these antibiotics, any anaerobic infection that is below the diaphragm, you give metro. Any anaerobic infection that is above the diaphragm, you give clindamycin. Both of them are excellent in treatment of anaerobic infections, metro or clinda. So we should not forget that. So that's that about. Then, of course, if we do a wet mount of the
Sorry,
discharge.
Dr. Babawale, sorry. You said anaerobic infections above the diaphragm is metro.
Clinda.
Okay, cleaner. Okay.
Clinda. Below metro. So if we do a wet mount, so we obtain sample of the discharge, we look at it under the microscope, we are going to see what we call the clue cells. So that's one of the criteria for making diagnosis. Clue cells, which are just vaginal epithelial cells that are colonized by the Gardnerella. So that is what we are seeing in this image. So we can see the clue cells, which are the vaginal epithelial cells that are colonized by the Gardnerella vaginalis. So they have this stippled appearance within the outer margin. It's like we are applying staple pin, to the outer margin. So they have stippled appearance. So once you see clue cells, they're talking about bacterial vaginosis. So the clue cells, the whiff test, which is mixing with 10% KOH, exacerbation of fishy odor, and the vaginal pH more than 4.5. It is only candidiasis that the vaginal pH is less than 4.5. In trichomonas, in bacterial vaginosis, it should be more than 4.5. But in candida, it is less than 4.5. So candida is one that maintains the normal vaginal pH. We're going to talk about those guys later. So let's just move. The zoonotic bacteria. Me, particularly, I will tell us not to worry ourselves about learning this table. No, because we will have learned them as we are reading all these things. They are just reiterating those things. We've not even talked about anaplasma. We're already seeing table. So anaplasma, zoonotic infection just means infection that transmitted between humans and animals. So animals play a role as a source of the vector that causes the infection. For example, anaplasma. We said it already that somebody that has infection from this Ixodes tick, they can transmit Babesia, they can transmit what other infection do we say? Babesia, anaplasma, what? For Ixodes tick.
That's anaplasma, the Q fever, rickettsia, right?
Lyme disease.
No, we have not mentioned Q fever. We don't mention Q fever today.
What's your question, Dr. Babawale?
Lyme disease, Lyme disease.
Lyme disease.
Yes, it's Lyme.
So Lyme,
Yeah, Borrelia, yeah. Borrelia
Borrelia.
and anaplasma, yeah. Thanks.
That's why I said BAB. Borrelia, anaplasma, Babesia. So those are the three infections transmitted by the Ixodes tick. Bartonella.
Yeah.
Bartonella is another zoonotic infection that can be transmitted by cats. So it can cause cat scratch disease, bacillus. I feel we are going to learn all this one later. Let's just leave Bartonella for now. Borrelia burgdorferi, that's a Lyme disease. Ixodes tick, that's a vector. Let's ignore Borrelia recurrentis. Nobody will ask us. Brucella. Brucella is the one that we said is characterized by the triad of undulant fever, arthralgia, myalgia, and drenching night sweat. So it's from unpasteurized dairy. So someone that is in contact with all those animals, those cattle, the secretion and all those things, person can develop brucellosis. So we want to give, who remembers the treatment? Although I've said it that we should not try to bother ourselves about it. But who can try to remember it? Who remembers it? The treatment for brucellosis. Okay.
That's the one like TB, right?
Cystoclane plus rifampin.
Yeah, but
Yeah, like
there's a first agent that you must always drop before you put your rifampin or your streptomycin.
is it doxycycline?
I already said cyclane.
Yeah,
Oh, okay.
okay. Sorry, I did not hear you.
Sorry, I didn't hear that.
So doxy is the first one. You now combine with either your streptomycin or your rifampin. Campylobacter, blood diarrhea. So because you can get it from animals and all those things, so it's also zoonotic. Chlamydia, Stachybococcus, you can get it from parrots. Coxiella bonnetti, Q fever, from aerosols of cattle and sheep amniotic fluid. Ehrlichia, this one is gotten from the Lone Star tick, Ehrlichiosis. Leptospira. So the most important one that we should just pay attention to, Anaplasma, exodistic, Borrelia, exodistic, um, Leptospira, animal urine, all these rodents, Mycobacterium leprae, Armadillo. So Armadillo are sources of this Mycobacterium leprae. Remember that we said that Lepromatous leprae is what? Leprae cannot,
Let's see.
it, it cannot survive outside the host. It must be somewhere. So the major reservoir is Armadillo in the US and humans too. So Pasteurella multicida. This is the only place we are going to talk about Pasteurella multicida. And I just want us to always have this diagnosis in mind whenever they paint scenario of somebody that is being bitten by dog and the person develops cellulitis, wound infection. So it can penetrate because the dog is going to inoculate that wound in the bite. So it can affect its tissue, which is down to the subcutaneous tissue and sometimes to the bone. So cellulitis, osteomyelitis from dog bite, Pasteurella, is dog that they usually like using. So it is not only rabies that dog can transmit. Pasteurella should also come to mind when we see dog bites. Rickettsia, all these rickettsia, we are going to talk about them. So let's ignore. Salmonella. Salmonella typhi is not zoonotic, but the Salmonella species that are non-typhi, they are zoonotic. Because those are the ones that we can transmit from all these contact with the animal, with the egg, with the poultry stuff. So those ones will not typically cause bloody diarrhea, but occasionally when they become invasive, they can cause bloody diarrhea. So once you just see self-limiting gastroenteritis in somebody that have eaten egg or something or contact with animals, and they grow something that looks like salmonella, you can confidently say that that is not Salmonella typhi, but the non-typhi species for salmonella. So maybe the person has been in contact with turtles, with the poultries, the egg, the all these things. So Yersinia pestis will cause plague, just like Yersinia enterolytica will cause what? Bloody diarrhea, will cause pseudoappendicitis, will cause reactive arthritis. So we should not forget. Yersinia enterolytica will cause pseudoappendicitis, because um, reactive arthritis and bloody diarrhea. But the pestis form is the one that causes plague. This is the only place we are going to mention plague too. Three things I just want us to remember about plague. Plague is transmitted by fleas. So it is fleas that contains this Yersinia pestis. And this fleas actually follows all these rats and dogs. So anybody that get in contact with all these rats and dogs can easily have this flea bite and from there develop this um, plague. So plague, three things: cutaneous, um, pulmonic plague, septic plague, bubonic plague. Sorry, there's no cutaneous. Pulmonic, septic, bubonic. So bubonic is just when you have inflammation of the lymph node. That's the commonest presentation. So when they say somebody suddenly have inflammation of the lymph node, no ulcer in the penis, but there's an inflammation of the lymph node bilaterally and all those things. And they said the person has been in contact with rats, all those things, or fleas, getting bitten by fleas or getting exposed to some rats. And there is uh, inflammation of the lymph nodes, particularly the inguinal one, bubbles. We know that that is Yersinia pestis. The person can have pulmonic one, in which the person just having features of pneumonia and all those things, chest pain, cough, hemoptysis, and all those things. And some people will just be sepsis. But most commonly, if they want to tilt our mind towards plague, they will put it in the bubonic form. So It's very rare, it's very unlikely that we're going to get question of plague. So I'm just mentioning just for knowledge sake. So let's talk about the rickettsial diseases. So 3 of them, very easy to remember. The treatment for rickettsia is one of those atypical infections, doxy again. So 3 forms: Rocky Mountain spotted fever, and the 2 presentation for 3 organisms. So one presentation is Rocky Mountain spotted fever and the typhus. So let's talk about the Rocky Mountain spotted fever. So spotted fever just means you are going to be seeing pinpoint rash. So something like this. You can see this pinpoint hemorrhage, petechial rash. So I think that's the basis of this spotted fever. So Rocky Mountain spotted fever presentation is caused by a rickettsial infection, but which species? Rickettsia rickettii. So the way me I learn it is, I know that Rocky is starting with R. So that means that the rickettsial species too must start with R. So Rickettsia rickettii. And the vector for that one is the commonest vector that we usually talk about, which is what? The tick. Just imagine the number of times that we have talked about tick today. Tick, 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 tick. Exotic tick, Lone Star tick. So tick is the vector for Rocky Mountain spotted fever, the Rickettsia rickettii. What is the triad of Rickettsia rickettii? We are looking for fever, headache, and after some time, they will develop the rash. Fever, headache, rash. That is all. But how are we going to know that this is Rickettsia rickettii rash? Number 1. The rash is centripetal in distribution. That is, it starts from the joint of the upper limb and the lower limb. It starts from the ankle, it starts from the wrist, then it's going to extend to the palm and the sole. So, in addition to what organism? Which organism also causes the rash that extends to the palm and the sole?
Coxsackie virus. I think Coxsackie A virus, and then secondary syphilis.
Thank you. So somebody that has Coxsackie A virus and secondary syphilis, in addition to Rickettsia rickettii, they will have rash that will be extending to the palm and the sole. So the rash of Rocky Mountain. So the way I just picture it is that maybe the mountain base is just maybe because we use our palm and our leg to climb mountain. So the rash will start from there. I don't know the reason why they gave it that name, but that's what I'm just thinking. So the rash will start from there. The wrist, the ankle, extend to the palm and the sole. And from there, we now move inwards towards the body to affect the trunk. That's centripetal distribution. So once we see that, we can confidently say that this is Rickettsia rickettii. And tick is the implicating vector. So headache, fever, and a rash. We know the pattern of the rash. So what about the typhus? So not the Rocky Mountain spotted fever, now the typhus. So this typhoid one, this one will also cause the headache, fever, and the other constitutional symptoms. We have 2 forms, the epidemic and the endemic. So the way I learn it is that I just know that, okay, epidemic, P is there, Rickettsia prowazekii. So it's fine if they ask us this question and we cannot give the answer spinally. It's good we take our time. Rocky Mountain spotted fever, there's R, Rickettsia rickettii. Epidemic type, so we are looking at the typhoid now. Epidemic typhoid, there's a P there, Rickettsia prowazekii. Rickettsia prowazekii is the one that is transmitted by louse. So the name is the longest, prowazekii. Louse is longer than fleas and ticks. So louse. Sorry, it's not even longer. It's not longer actually. I'm just looking at the spelling. So, but it will stay. I don't actually know of any acronym that can give us for the last, but me, I'm used to it. So by the time we, read it, it stays, it stays. So louse is for prowazekii. The fleas is for the typhi. So we have exhausted them. So the tick is for the Rickettsia rickettii, the louse is for prowazekii, and the flea is for the Rickettsia typhi. So Rickettsia prowazekii, Rickettsia typhi, both of them cause the typhus. Rickettsia rickettii cause the Rocky Mountain spotted fever. So how do we separate them? The typhus from the Rocky Mountain spotted. You see, the typhus and the Rocky Mountain RMSF, they are like the same presentation, but the difference is that this pattern of the rash, that is what is different. The pattern of the rash. So for the typhus, both of them, the rash will not start from the extremities. It will not start from the ankle, the legs, the palm. No, it will start from the trunk and move outwards. And even if it moves outwards in a centrifugal distribution, it's not going to affect the palm and the sole. So we can confidently rule them out. So that's that about the typhus. They will cause the headache, the fatigue, the myalgia, and those things. And by the sixth day, the rash will start appearing, and the rash will start from the trunk and move to the extremities, but it will not affect the palm and the sole. Unlike in rickettsia rickettsii causing the RMSF, that one will start from the extremities, get to the palm and the sole, which is what we used to climb the mountain. Then we now move to the trunk. So, what about the atypical reason that rash is rare? Ehrlichiosis and anaplasmosis. See, my people, to be honest, we don't really need to know how ehrlichiosis or anaplasmosis presents, because what we are looking for in the question is what? Monocytes in morule, granulocytes in morule. Once you see that, you don't give a damn about how the person presents, because the presentation is not classic. Anything can present that way. Headache, nausea, vomiting, myalgia, fever, end organ failure, bleeding. We have said nothing. So many things can present that way. But by the time they do the blood examination and they are seeing monocytes within the morule, which is the ehrlichiosis organism, morule in monocyte, we know that that is ehrlichiosis. When they are saying morule in granulocyte, that is anaplasmosis. That is all. Both of them are transmitted by tick. The tick for anaplasmosis is what? Ixodes tick. The tick for ehrlichiosis is the Lone Star tick. We should not worry. They will not ask us the name of the tick. It's just making diagnosis, from that blood work, the monocytes. And so let's look at how they look like. So this is a Rocky Mountain spotted fever. You can see the rash, that is pinpoint hemorrhages, petechial hemorrhages in the body. So that's the typical rash that they have. Then we can see that this is which white blood cell is it for someone that has done hematology. Which one is this? Is this a monocyte or a granulocyte? This one, this B. Anybody?
The B, that's the
Monocytes.
that's
This is
the
monocytes.
that's the monocyte.
And C is granulocyte.
Yes, yeah.
So once you see everything looking curved like this, it's like to be a granulocyte. So granulocyte. So you can say that C is talking about root infection. So what's the infection for C now?
That's anaplasma.
So that is
The
anaplasma.
granulocyte.
This is anaplasma. Then B is what?
That's the what's it called? Ehrlichiosis.
So B is ehrlichiosis. So we can see.
Yeah, the ehrlichiosis infection.
So you can see the morule, this small one within the monocyte. For ehrlichiosis, we can see the morule within the granulocyte for anaplasma. So moving on to mycoplasma pneumoniae is another typical organism. So this is where we are going to talk about typical pneumonia.
Dr. Normally, there was this discussion I had with you, was it yesterday or 2 days ago, about where we need to know the important geographical locations.
Mm-hmm.
So I don't know, maybe it's important in any of this.
It's not. It's not.
Okay.
It's not.
Okay.
Once you see all those presentations, you make your diagnosis. When we start talking about the fungi, that's where we'll talk about. And even if only maybe one organism, geography, location, is important. So all these ones, they are straight up from the features. You pick it. You won't wait for the geographic location. So, then I almost forgot Q fever. So Q fever is caused by Coxella bonnetti. Coxella bonnetti is different from ehrlichiosis and anaplasmosis because it has no vector. It's not transmitted by any vector. So Q fever is just notorious for causing problem with the lung and the liver. Fever with lung and liver pathology. So it can cause an atypical form of pneumonia. And at the same time, it can cause granulomatous hepatitis. So we are going to see granuloma formation within the liver. So the person can be having right caudal upper abdominal pain, jaundice, and the like. So how do they get this Q fever? An individual will get Q fever from inhalation of the microbe from the amniotic fluid of cattle and sheep. That's where it comes from. So if it's not present in the cattle or sheep and it's present in soil, they'll be present there in endospore form. So they survive outside the host, either the sheep, the cattle, or human being, outside as an endospore. So, but when we are within the sheep or the cattle, it is the amniotic fluid that actually contains the high amount of this Coxella bonnetti guy. So once somebody works in all these places that they butcher animals and person as takes in the amniotic fluid droplets from the abattoir, the person can develop Q fever. So problem with the lung and the liver, hepatitis and pneumonia. At the same time, it can also cause endocarditis. So it's one of the um, culture negative causes of endocarditis. So aside the ASEC organisms, Q fever is another cause of culture negative endocarditis. But that is, by the time we take a portion of the abscess in the lung, in the heart, and we want to culture it, it will not grow anything. It will be negative because they don't grow on normal culture media, Coxella bonnetti. So I think that's that about Q fever. The aerosols from the cattle and the sheep amniotic fluid, and the fact that it can cause lung and liver pathology predominantly, and in some situation, it can cause culture negative endocarditis, Q fever. So Mycoplasma pneumoniae is one of the causes of atypical form of pneumonia. When we say pneumonia is atypical, there are some classic features that we are looking for. Number one, that pneumonia is not going to be shared with sputum production. So the cough that they will be having will be dry and non-productive. By the time somebody has a dry, non-productive cough, it's likely to be an atypical cause. Number two, when we give antibiotics and the infection does not typically respond to the usual antibiotic that we use in treating pneumonia, we know that it's likely to be atypical. Number three, if the infection is protracted, pneumonia is an acute inflammatory disease. Pneumonia should subside with like 1-2 weeks. When it's now protracted, going for a long course, we should suspect atypical form of pneumonia. So that is that about. An atypical form of pneumonia, in addition, they have extrapulmonary signs and symptoms. So somebody having a GI problem, CNS problem, addition with pneumonia, that is likely to be atypical pneumonia. So non-productive sputum, poor response to antibiotics, classic antibiotics, protracted course, extrapulmonary manifestation, atypical pneumonia. So one of them is Mycoplasma pneumonia. We've talked about Legionella too as one. Legionella is one, Mycoplasma is another one. So anything aside the typical things like Kleb and Strep pneumo causing pneumonia, all those other ones that cause pneumonia like Mycoplasma, Legionella, Chlamydia, Haemophilia, all those ones are atypical cause of pneumonia. So one thing I just always want to emphasize with respect to this Mycoplasma pneumonia, number one, is that it typically occurs in people that are young. So someone that is less than 30 years that is living in close contact, because it's transmitted to the respiratory tract, they can develop Mycoplasma pneumonia, number one. And Mycoplasma pneumonia is one of the causes of walking pneumonia. What do they mean? You will notice that by the time you do your x-ray of this patient, what we are going to be seeing will not be in keeping with the presentation of the individual. You see the patient walking moving up and down, like the person doesn't have any problem. And you look at the X-ray, it's very bad. You see like diffuse interstitial infiltrate. Almost all the zones of the lung is having this pathology, and this guy is just walking as if there's nothing. That is atypical pneumonia, the walking pneumonia, which is typically caused by Mycoplasma pneumoniae. So they have this walking pneumonia, they are walking, they are hale and hardy, but the presentation is not in keeping with the level of damage in the lung. What is another thing about Mycoplasma pneumoniae? Mycoplasma pneumoniae, when we're talking about gram staining, we said is one of the organisms that cannot be cultured. Why? Anybody remembers? That cannot be stained. Why is Mycoplasma pneumoniae not stained on gram stain? Anybody? Hello? Are we there?